A very good afternoon to our fellow medical colleagues, physicians, and MOs. I'm Lim, Medical Officer from the Radiology Department of Mayo Hospital. Thank you, Dr. Bendy, for shedding a light on the patient's clinical history, presentation, and subsequent management. So today I'll touch more on the patient's radiological imaging findings, and later on in the slide, I will conclude a few MRI or CT findings from the previous retraces over the years. Without any further delay, let's proceed with today's presentation. As you can know, this is a young patient in his 20s, male, underlying SLE for the past 4 years duration. So there's an initial request by medical team for plain CT brain on 25th of April, after patient developed a first episode of fitting. There's no baseline CT or MRI was done prior to this. Okay, as you can see from these few selected CT brain plain images, you can see that the ventricles, cerebral cell site, silver fissure are relatively more prominent as for the patient age, in keeping with cerebral atrophy. However, it's slightly more pronounced over the left side. So initially, our impression is that the left-sided prominent CSF spaces, which may represent left cerebral hemiatrophy, is a relatively non-specific findings in which there's many causes that can cause this condition, which include ischemia, infection, post-ictal cerebral hemiatrophy. 3 days later, this patient underwent MRI brain with impression to raw cerebral lupus and also in addition to raw cerebral venous thrombosis. In the subsequent few slides, I will show you a few MRI sequences, which include the FLAIR sequences, the TOF MRA, which is our time of flight MRA, and as well as 3D brainlet post-contrast. As you can see from this FLAIR sequence, as I scroll down, there's an area of FLAIR hyperintensity involving the subcortical white matter region of ventral frontal lobe, as well as the periventricular region of ventral parietal, as well as ventral occipital lobe. And you can see there's a generalized cerebral atrophy, more pronounced over the left side, as noted in previous CT. As for the MRI TOF image, you can see that all the circle of villi vessels are glossy pattern with no evidence of vital appearance, aneurysm, or vascular malformation. The A1 segment of the right anterior cerebral artery are relatively smaller in caliber as compared to the left side. As you can see also in the reconstructed 3D images of the MRI TOF, here you can see relatively smaller in caliber of the A1 segment over the right side, in keeping with hypoplasia. And as for the 3D brainlet post-contrast, there's no abnormal focal area of enhancement over the area of hyperintensity that we mentioned just now. There's no lateral meningeal enhancement, and the dura venosus sinuses are all well opacified with no filling defect within. So the constellation of findings of subcortical and periventricular white matter hyperintensity suggestive of the small vessel disease and also vasculitis, given the history of SLE in this patient. And there's a background of diffuse cerebral atrophy. And then there's no evidence of cerebral venous thrombosis as well. Back to today's case discussion on cerebral lupus. In order for us to understand cerebral lupus, first we need to know what is SLE, what is its pathogenesis, as well as how does it involve our systemic organs. So firstly, what is systemic lupus erythematosus? So in short, SLE is a complex autoimmune disorder which is believed to be multifactorial in its pathogenesis. The various factors such as genetic, environmental, immunoregulatory, as well as hormonal factors are believed to play a role in the generation of autoantibodies, immune complexes, inflammatory cytokines, as well as T-cell activations, which will in turn causing various organ damages in the patients with SLE. I believe that we are well aware of classification criteria for SLE, which is first to be published by American College of Rheumatology back in year 1971. This criteria further revised in 1982 and undergo another modification in year 1997. In order for the patient to classify as SLE, the patient must fulfill at least 4 out of 11 listed criteria, either serially or simultaneously. Lately, there's a new criteria being proposed by European League Against Rheumatism alongside with American College of Rheumatology in year 2019 for the classification of SLE. According to this classification, in order for the patient to be classified as having SLE, the patient must fulfill the entry criteria, which is the antibody and anti-nuclear antibody, and a titer must be at least 1 in 80. Secondly, the patient must have at least 10 points in order to be classified as SLE. The points must be contributed from at least one of the clinical domains and listed in this table. However, there is no universally accepted diagnostic imaging criteria for SLE at the moment of time. From this table, you can know the systemic involvement of the SLE, which involve the lungs, the hearts, the GI, genitourinary, MSK, as well as neurology. For the purpose of this presentation, I will focus more on the neurology manifestation of the SLE. Okay, from this table, you can know that SLE can attack on the central and also peripheral nervous system, resulting in neuropsychiatric syndromes. As you can see on this table, there's a long list of neuropsychiatric syndromes. However, there's not every of these neuropsychiatric syndromes have their own radiographic features. However, as for the radiological imaging, it might be very helpful for a primary team in terms of evaluating for the cerebral vascular disease, demyelinating syndrome, as well as myelopathy. I'll focus more on the cerebral vascular disease in my presentation today. Okay, this is a study conducted by Sespani and his colleague back in 2003. This study is mainly to study what is the common MRI findings in the patient with SLE. They enrolled about 80 of the patients with SLE and noted that around 40 of them, which is half of them, having normal MRI findings, 20% having cerebral infarct, followed by cerebral atrophy, and lastly, the small subcortical lesions. Okay, these two MRI brains selected images of a T1 sequence. As you can see, these two belongs to a patient of reproductive ages. On the left belongs to a 24 years old female, and the right is a 21 years old female. As you can see on the left, the brain sulci are relatively normal for age. However, on the left, you can see the sulci widening with prominent CSF bilaterally. This is in keeping with cerebral atrophy. Okay, these patients, you can see the selected T2 and FLAIR sequences reveal that there are several T2 and FLAIR hyperintensities, which is less than 1 cm, distributed in the deep white matter of bilateral central semi-ovale. This is in keeping with chronic small vessel ischemia. These images belong to a 48 years old female with a 15 years duration of SLE and positive lupus anticoagulant. Okay, there's a large amount of study concluded that small vessel disease and cerebral atrophy is a common finding in about 25% of the patients with SLE. However, some literature suggested that can be up to 30 to 40% of patients can present with small vessel disease and cerebral atrophy. In radiology, we use a Fazekas grading for us to quantify the amount of the T2 FLAIR hyperintensities in the subcortical and periventricular region. On these images, T2 axial brain, you can show that on the left, you can see that there's a right parietal infarct in the background of prominent ventricles and cerebral sulci. This is in keeping with cerebral atrophy. And on the right, you can see there's a left cerebellar hemispheric infarct. This MRI brain belongs to a 39 years old female with a long history of SLE and positive anti-cardiolipin antibodies. From these axial brain images, belongs to a 45-year-old female SLE with antiphospholipid syndrome. As you can see the photo on the left, you can see this the flare axial images show that there's a border zone infarct, or what we call is a watershed infarct. And on the right, you can see there's a small left basal ganglia lacuna infarct. Next, we have another SLE patients with acute onset of body weakness for 1 day. As you can see from the left, this selected CT brain plane images axial view should alert you to the diagnosis of acute right MCA infarct as evidenced by hypodense right MCA sign. And you can see there's an ill-defined hypodensity along the right MCA territory distribution. And on the right, you can see clearly those area of acute infarct with loss of gray-white matter differentiation. Vasculitis is one of the complications of patients with cerebral lupus. Before we're looking at the radiological imaging features of vasculitis, let us familiarize with some of the normal CT and MRI brain images. As you can see for this diagram, it shows you the normal anatomy of circle of Willi. The circle of Willi comprises of vessels supplying the anterior and also posterior circulation. For the anterior circulation, we have internal carotid arteries, which giving rise to the MCA and ACA as the terminal branches. And you can see we have the ACOM, the anterior communicating artery, which communicating both the right and left anterior cerebral artery. These vessels form our anterior circulation. However, please note that the middle cerebral artery, although it supplies our brain, is not considered part of the circle of Willi. As for the posterior circulation, we have the posterior cerebral artery, PCA, which is formed by the basilar artery, and we have the PCOM, the posterior communicating artery, which communicates between the posterior cerebral artery and the internal carotid artery. So, hence, the posterior communicating artery, the PCOM, it communicates between the posterior circulation and anterior circulation. This is the axial MRI TOF. The time of flight images show you the circle of Willi. What is mean by MRI TOF is this is an MRI technique that allows us to visualize the circle of Willi without the need of administering the contrast. So on this for the MRI, we can reconstruct it into 3D view as shown in these diagrams. And you can see from what I mentioned just now, the circle of Willi. As you can see here, we have a bilateral ICA with giving rise to the MCA and also the ACA. And also we have the anterior communicating artery, which connecting both the ACA. This is our anterior circulation, and then you can see the basilar artery giving rise to bilateral posterior cerebral arteries. And the PCOM artery is not well visualized in these MRI images. Okay, next I will show you a normal CTA brain images of one patient. This is a normal CTA brain finding. As you can see from these images, you can see there's a bilateral ACA, and this is the ACOM, and then this is the MCA, and this is the ICA, and this is a PCOM on the left, PCN bilaterally, and then basilar artery going to the vertebral arteries bilaterally. Although vasculitis is one of the complications for patients with SLE, however, there are a lot more disease or conditions that can contribute to vasculitis. According to the 2012 revised International Chapel Hill Consensus Conferences, they came up with a classification of vasculitis which is according to the size of the involved artery and also as well as its associated pathologic lesions. As you can see on this table, Takayasu arthritis is grouped under large vessel vasculitis because of its predominantly involving large intracranial vessels. However, for SLE, it's grouped under as vasculitis with systemic disease. According to the study conducted by Tasnim and his colleague in 2004, it shows that SLE typically affects small vessels less than 100 micrometer. So what happens in patients with SLE is that there's evidence of fibrinoid necrosis involving the vessel wall. So in an attempt to repair the vessel wall through endothelial proliferation, it causes intima fibrosis and also subsequent vascular occlusion. So hence the patient with SLE, there's a higher risk of small vessel disease, stroke, as well as vasculitis. And also they also highlight some of the major MRI findings for patients with SLE, which is more than half of the cases presented with subcortical and preventricular white matter hyperintensity, 30% of them with cerebral hypertrophy, and a small proportion of them, which is around 3%, with ICB. Okay. This is one of the examples of the case with evidence of vasculitis. As you can see, it involves the left-sided anterior cerebral artery, and you can see there's a multiple focal segmental narrowing involving this vessel, or what we call is a string of beads appearance or beaded appearance. Okay, another case, we have 34-year-old female SLE with APS. You can see there's evidence of right border zone infarct in these flare images. And you can see in the MRI TOF image, you can see there's significant vascular narrowing involving bilateral MR segment of middle cerebral artery and as well as bilateral internal carotid artery. This patient was followed up 2 months later with MRI TOF, noted that there's a resolution of the arterial stenosis with a good caliber of these vessels. Okay, we have another case, 45-year-old female, altered mental status with seizure. On the MRI images, this flare sequence, you can see there's a multiple patchy areas of hyperintensity involving the gray-white metal junction bilaterally, likely to be ischemic in nature. This is suggestive of CNS vasculitis. This patient was subsequently worked up for SLE and was noted positive for the rheumatoid markers, and the patient was started on a trial of steroid and rituximab for 2 months. According to this study, but they didn't provide the follow-up MRI studies, but they did mention the patient improved clinically and radiologically. Okay, in some of the SLE patients, particularly patients with antiphospholipid syndromes, they have a normal hypercoagulability, so they have a higher risk of developing recurrent stroke, venous thrombosis, and as well as PE. So this is one of the example of the patients, which is a male patient having a right-sided headache for 3 weeks. As you can see in the MRI brain contrast study, you can see there's extensive vein defect involving the right transverse sinus and also actually involving part of the left transverse sinus as well. So this in keeping with the transverse sinus thrombosis. And the patient with SLE, they are at particularly higher risk of intracranial bleed as well, partly due to presence of uremia, thrombocytopenia, and also underlying hypertension. So this is a SLE patient coming with headache for 5 months. You can see there's an acute intraparenchymal bleed involving the left temporal lobe. Please note that the patients with SLE, they can come with various forms of ICB, like intraparenchymal, subarachnoid, subdural, or hemorrhagic infarct. And these patients, they also have particular risk of aneurysm rupture, complicated in SAH as well. Okay, for patients with SLE, they actually have a high risk of developing a condition what we call Liebman-Sachs endocarditis. It's a condition of non-bacterial thrombotic endocarditis, which tend to involve the mitral and aortic valve. So this kind of patient, they tend to develop the microemboli to the brain. So this is a case of patient SLE with mitral valve endocarditis undergoing immunosuppressive therapy. MRI contrasted brain showing that there's a left ventricle lesion with peripheral rim enhancement and central necrosis. This was showing to be a candida cerebral abscess. As for the radiological differential diagnosis, I put out two. First is acute demyelinating encephalomyelitis, or what we call in short is ADEM. So it's actually a condition typically follows the recent history of viral infection or vaccination. Usually it occurs 1 to 2 weeks prior to the onset of symptoms. So as for the radiological features, usually you can find lesions high signal intensity on T2 flare sequence, and usually it's in subcortical distribution with surrounding edema. So in some of the cases, there will be involvement of the brainstem and thalami, and some with enhancement or peripheral restricted diffusion. Secondly, we have a lymphomatoid granulomatosis. It's a rare type of non-Hodgkin lymphoma with concurrent Epstein-Barr virus infection. As for the radiological imaging features, usually they have multiple lesions within the supra and infratemporal region, white matter region, extending into the cortex. So some of this lesion can have a punctate or linear enhancement, as well as leptomeningeal and cranial nerve enhancement. As a summary, SRE is a complex autoimmune disorder with multi-systemic involvement. The CNS manifestation is very wide. So we have, as what I mentioned just now, we have a whole list of neuropsychiatric syndromes. But however, not all of these having their own radiographic features. So, and then these features are mostly non-specific and radiographically indistinguishable from other appearance due to other etiologies. However, the radiology imaging is very helpful in evaluating for the complications of CNS involvement. For example, the cerebral vascular disease, which can help the primary team in guiding for the further management of the patients. And here's my list of reference, and this is the end of my presentation. Thank you.